Hi, everyone. This is Dr. Srinivas Iyengar. I'm the Director of Structural Heart at the Boulder Community Health Hospital in Boulder, Colorado. Thanks for joining us on SIF Virtual 2020. Today, I'd like to present a fantastic case of MitraClip edge-to-edge repair. Here are my disclosures. So first and foremost, let's talk about MitraClip. It's a needed bridge. Patients have needed an alternative form of mitral valve therapy other than traditional open heart surgery or even minimally invasive surgery for the last 30, 40 years at least. Higher risk procedures obviously bring higher rates of complications for open procedures. The MitraClip has established itself in the high risk mitral valve arena, but mainly in elective cases. In select situations, however, it can also be utilized for patients suffering from acute and life-threatening conditions. So with that, let's go into the patient history. This is an 81-year-old, very frail male with a history of atrial fibrillation and remote traumatic chest injury with an infected sternum from apparently a motor vehicle accident from years ago. He presents to the hospital with acute worsening of shortness of breath. His physical exam shows he's tachycardic with a 4 out of 6 systolic ejection murmur at the apex. His echo shows a normal ejection fraction. However, there is a flail posterior mitral leaflet with severe mitral regurgitation. The patient was stabilized initially with IV Lasix and IV nitroglycerin, and the blood pressure had stabilized. And these images are obviously a little bit slow, but what I'd like to show here is the transthoracic parasternal long view. And we'll go to the next slide here to see if we can see that a little bit better, and maybe it'll run a little bit clearer. And here you can tell just by looking at it in the parasternal long view, what we're seeing is actually significant mitral regurgitation. And as you can see the color, how the color is directed away from that posterior leaflet, which is the flail leaflet at this point. And what we've seen just by these two views, clearly severe mitral regurgitation and an ejection fraction that appears to be normal. The patient does have a history of atrial fibrillation. However, you notice there is adequate squeezing of the left ventricle in this position. In this view, we're still in the parasternal long axis, and we're just getting a closer look at both the anterior and posterior leaflets. As you can see, they're quite thickened in this view. But you can tell by these slow motion views of the valve that it clearly is a thickened, heavily thickened valve. And again, we cannot see any torn cords in this view, but again, you can appreciate how the two leaflets appear. And again, this is a redemonstration on color of the valve and the significant amount of color. Now I want to pay close attention. If you can see just in that slow motion pic, the regurgitation is actually circular. It's actually circulating in the left atrium, which shows you how severe the amount of regurgitation is. So you can see there clearly like a crescent-like view of the actual color of the jet, which is actually circular in nature, semicircular. And in this view now, we're in the four-chamber view. And what we're looking at here is, again, the thickened leaflets of the mitral valve. And again, the posterior leaflet being almost prolapsing into the left atrium. And you can tell here by the motion when it does play through of the posterior leaflet not coapting properly with the anterior leaflet. And here again, we can now see the color demonstration, and you can clearly see the regurgitation filling in the entire left atrium. Following this surface echocardiogram, we decided to proceed with a TEE, transesophageal echocardiogram, to evaluate the patient's underlying mitral dysfunction further. I think this gives a much better view, again, of that posterior leaflet, and you can almost see some minuscule areas of cord that are torn as well. And again, another close-up view on his TEE of the cords themselves. And here is color demonstration across the leaflets. Clearly, you can see the jet itself, obviously moving opposite of the prolapsing leaflet, quite severe in nature, and again, curling around into the left atrium. Here we're looking at a 3D reconstruction of that leaflet, and I think you should pay close attention to what you see in the middle of the leaflets themselves. It almost appears that there's a finger-like projection coming across, which apparently indicates the torn cord or leaflet that is actually extending across that area. Once again, another redemonstration in another view under TE of looking at the significant prolapsing posterior leaflet with the concomitant extremely severe mitral regurgitation. So at this point in time, we've established that the patient clearly has severe mitral regurgitation from a degenerated mitral apparatus or leaflets. And at this point in time, we also wanted to show you again, if you see this, this is called blunting of the or reverse flow reversal of the pulmonary veins. And you can clearly see here, this is an abnormal tracing that's going through the pulmonary vasculature. So our patient evaluation, the patient was evaluated by CTS, which is cardiothoracic surgery, and deemed to be a high risk given frailty and his prior sternal issues. Additionally, the patient was also very hesitant about any open chest procedure. He did undergo a catheterization which showed normal coronary arteries. His PA pressure was markedly elevated at 70 millimeters of mercury, which was also a red flag for our surgeons who felt this was even adding to the risk score for the patient. His cardiac output was reduced at 2.5 with an index of 1.7. So after a thorough discussion with both our surgical colleagues as well as the patient, we decided to move forward with a MitraClip procedure. So the patient was brought to the hybrid catheterization lab. The access was uneventful, including the transeptal access. The patient was hemodynamically stable during the crossing, and images were once again retaken. Again, this redemonstrates how that posterior leaflet is in view, and you can clearly see that there appears to be some flail issues involving the posterior leaflet. Here, we're measuring our flail gap, and we have a distance of 0.58 centimeters measured in this view. Once we had accomplished this, we decided to proceed with placement of a MitraClip, and this was an XT that we utilized. The XT was placed in A2, P2 positioning initially, just to see over the major PISA or the major regurgitant flow of the mitral orifice. And these images now demonstrate the clip in place, but not yet actually grasping. We just wanted to make sure we were over the main jet. But again, as we all know, performing these procedures, not every time can you land your clip over the direct jet, as there may be multiple jets involved. After we did cinch down that first clip, you can see clearly that we have both leaflets in play here in the clip, but however, you notice there's still a significant amount of color coming from the lateral side of the clip. At this time, the decision was made that we were not going to finish the MR off with one clip. And oftentimes in situations like this, when you do have a flail leaflet or in severe MR, you will need more than one clip utilization. So hence we decided at this point to deploy the first clip and then to plan a second XT once we have assessed gradients. And as you can see here, the 3D reconstruction of how we were actually looking at the valve leaflets after we placed the clip. And again, making sure that when we're seeing the owl eyes, that we want to obviously close the largest area of the regurgitant orifice. The key here, of course, is gradient checking after your first clip. Obviously, a second clip would not be indicated despite the regurgitation if your gradient is significantly elevated. And his gradient after the first clip, as I recall, was only about 2. So here we are with another 3D reconstruction with the second clip in place. As you can see here now, we've made the owl eyes, which is again critical when we're placing the clips. The second clip is standing parallel to the first clip here in this view, and we wanted to obviously make sure that we have had good success in reducing any type of excessive regurgitation. Again, the expectation that you will reduce it to 0 is not realistic, but rather you want to reduce the regurgitation as far as possible. And here is our viewpoint here after that second clip is placed. And you can see clearly from the two different viewpoints that we have here that there's still a trivial amount of regurgitation or mild regurgitation, but it is absolutely significantly reduced since the initial presentation of the patient. Now, the thing here is the gradient was only approximately 3 to 4 at this point, and we still have that jet that you could see there past the lateral aspect, and we could have actually moved for a third clip. However, I feel it's important for all operators who are watching to understand that we don't just treat color, but rather we utilize all types of variables in deciding to place another clip, including how the color looks, but also how is the gradient across the mitral valve. Additionally, is there hemodynamic changes that can be visualized? And one important facet that I was going to mention initially is in his diagnostic catheterization, as well as on day of this procedure, his V waves were in the mid 30s to 40s. After the placement of the second clip, his V waves significantly reduced and they were down probably in the upper teens. So we had an absolutely great reduction of hemodynamics or a change in hemodynamics in the positive immediately after the second clip. Additionally, you can look at the pulmonary vein flow, and here you're seeing a reversal, a non-reversal actually. You're seeing it go back to its baseline or where it should normally be compared to the initial pulmonary vein reversal that we had seen on the initial TEE. So we had hemodynamic parameters that pushed us to the point to say, though the color was remaining, again, everything else looked pretty good. And we felt at this point in time that no further clip would be necessary with 2 XTs in place. And this is one of the final views you hear. Again, we're accepting that there's going to be medial and lateral jets that are present, but obviously the meat of the jet has been taken care of. And again, as the hemodynamic parameters have showed us, this was actually appropriate because he really did respond to these 2 clips in place. So post-procedure, the patient was weaned off all IV medications, was ambulating on post-op day number 1, and was discharged on post-op day 3 to rehab. Progressed very well. He's currently living at home independently, and his 30-day follow-up surface echocardiogram showed mild residual MR with a normal ejection fraction. So the take-home points here are not only is it important to understand in certain cases of this matter where you have a flail leaflet and severe MR, that MitraClip can be used in a non-elective setting. Additionally, you will most likely need to utilize more than 1 clip to get an adequate result. However, to perform a zipper-like procedure with multiple clips may not also be needed if you get excellent hemodynamic payback or findings after your second clip. So we kept this all in mind and the patient actually did quite well. With that, I'd like to say thank you very much for your time today.